All right, in chapter 3, we are going to talk about pharmacokinetics. The the term pharmacokinetics simply means pharma means medicine, we know that, and kinetics means movement. So in other words, we are going to focus on what the body does to the drug after we take the medication. So how does the drug move inside our body and what happens to it? So there are four processes of pharmacokinetics: absorption, number one; number two, distribution; number three, metabolism; and number four, excretion. And we are going to talk about these four things in detail right now. So the first one on the list is absorption. Well, absorption simply means when the drug is absorbed or move from site of administration to bloodstream. So if you're going to apply this medication on your wrist, on your hand, something that we call a topical medication, the absorption rate is going to be different versus if you are going to take that medication by mouth. So remember, when you take the medication by mouth, the medication has to go through your stomach and small intestine. So the rate of absorption is going to be different. Now, the rate of absorption will be very different if the medication was through IV. When you give IV medication, let's say IV antibiotics, you're releasing the medication directly into the bloodstream. So one can argue that absorption doesn't have to take place. The absorption is when you move from a site of administration to the bloodstream. But if you're giving IV drug, you're already in the bloodstream. So there's no absorption, or you can say absorption is very fast, or that step is actually is skipped, if you will. Okay, another concept is that absorption is faster on empty stomach, and it is slow when we eat food, and more specifically if it's a high-fat meal. And we know that. And remember, the absorption rate is also slow during vasoconstriction. Or in other words, you can say vasoconstriction will slow down the rate of absorption. And if it's a vasodilation, when you dilate, you increase the rate of absorption. And that makes sense. You know, when you constrict, you are going to decrease the diameter of the blood vessel. So the rate is going to be slower. All right. So one of the main factor or variables for absorption, a different type, different rate of absorption, is really the route of administration. As I mentioned before, PO is going to be slower than IV, and so forth. And another interesting point is the form of the medication. For example, is it a liquid or is it a capsule? And we know that the liquid medication will absorb faster versus if it was a tablet or extended release medication, and so forth. When we take a pill or any medication by mouth, we have to face liver as well before we really start metabolizing the drug. So when you take a medication by mouth, I'll try to draw a diagram, not a diagram, but a little cartoon here, if you will. When you swallow a pill, and the medication is going to go into your stomach, of course, right? So here's the medication, and from here, then it will go to your small intestine, duodenum, jejunum, and ileum. Now, from here, you have to face liver. So liver is sitting right here, and before the medication goes to your heart, if you will. And And please, this is just a cartoon. We know that that's not how liver look like, and that's not certainly not heart or stomach look like. But the point I'm trying to make here is there's a concept of a first pass effect. Drugs that are absorbed from stomach, from here, and small intestine, they travel to liver where they may be inactivated before reaching the target organ or organs. Now, some drugs, for example, and we call that first pass effect, and the example that I have here is nitroglycerin or estrogen. Now, nitroglycerin is extensively metabolized when they first pass through the liver, something that we call first pass effect. Because liver will extensively metabolize nitroglycerin, then you really need a large amount of drug so if you want the effect of that medication in the body. Now that becomes a problem. You have to take a significant large amount of drug to get the same effect, because you have to go through liver. Now therefore what we do in order to really bypass liver, in order to solve that problem, instead of taking a large amount of a PO nitroglycerin, we give nitroglycerin sublingually or topically, like a patch. By doing so, we will avoid first pass. And remember, our mouth or oral cavity is very vascular. So when you put a medication such as nitroglycerin under the tongue, it will dissolve very quickly and it will enter into the vascular system. So you're not going to swallow the pill. So you will bypass your GI tract. That was the point I'm trying to make here. So, and we know that we take small dose of a sublingual medication as if you were to take the medication by mouth, then you would require high dose. So that's first pass effect. All right, so the second point is a distribution. So distribution involves the transport of drug molecule within the body. So there are many factors that can affect distribution. For example, blood flow to the tissue. So as I'm sure you're aware that if you have a better flow to the body part, then if this is your let's say foot, and then you have better flow, blood flow, then you would have, it would be easier for us to treat the infection. Let's say you have an infected toe and then we prescribe antibiotic, but if the blood flow is not as good, if the blood flow is poor, then it will be difficult for the drug, in this case antibiotic, to travel all the way and towards the foot. So versus if this is a young patient, let's say, otherwise a healthy patient, stepped on something and then has a wound, we prescribed antibiotic, and then the blood flow is great, and then the drug will distribute better or more effectively. So blood flow to the tissue is one of the factor of distribution. Another one is a drug protein binding. Protein binding is a very important factor in a drug distribution, because most drugs form a compound with the plasma protein, usually like albumin, and that becomes a carrier. So these protein, they act as a carrier for drug molecules. So if you have a client who has a poor appetite or low albumin levels, so you can have a variation in distribution. We do have some barriers to drug distribution, and that's not always a bad thing, but for example, we have a blood-brain barrier, or we have a fetal placental barrier. So remember, blood-brain barrier, it does not contain pores, so it's supposed to protect the brain from pathogen and toxins. And also recall that lipid-soluble drugs are able to cross blood-brain barrier. So these barriers are not fully developed in neonates, so you have to be very, very careful when we prescribe medication to these little patients. Inflammation can actually increase permeability, so at that time drugs are able to pass through. Another barrier, as I mentioned, is a fetal placental barrier. So the purpose was to prevent harmful substance from passing from mother's bloodstream to the fetus. However, this is not 100% effective. In a way, it's not a solid wall. It is ineffective against some substances such as alcohol, cocaine, caffeine, and some prescription medication can cross over. So you have to be very, very careful when you prescribe any medication to a female patient of a childbearing age. Make sure we sit down with them and do a very good education. There are some drugs that are very, very toxic to the fetus. One example I can think of is anytime I prescribe medication, let's say for a bipolar patient, and then we are going to prescribe Depakote, we always sit down with the patient and give education and ask the patient not to become pregnant and use precautions, at least 2 different types of safety precautions. And if there's any question, any doubt that the patient and you become pregnant, we need to be notified immediately and we need to stop the medication and so forth. So that's very, very important. Metabolism is number 3. Metabolism is a process that changes the activity of a drug and makes it more likely to be excreted. We need, before we excrete the medication, before we get rid of the medication from the system, we need to metabolize the drug. So some textbook will use the term biotransformation. It's the same thing. It's simply a method by which a drug will be the drug that are inactivated or biotransformed by the body. Let's see. The primary site for metabolism is a liver. We know that. Let's see. Okay. There are multiple enzymes that play a role in metabolism, and we are going to talk about those enzymes in a minute. Before we move forward, prodrug. Let's talk about prodrug. I'm going to introduce a concept here. So prodrugs are pharmacologically inactive drug. These are not active drugs; they're inactive. Some medication that require metabolism to produce a therapeutic action. So in other words, these drugs have prodrug will have no pharmacological activity at all until they undergo metabolism. So they're inactive. So when you swallow these medications, the example I have here is enalapril, which is an ACE inhibitor for blood pressure, right? And you know it's ACE inhibitor because it ends with a pril. So when you take enalapril, it is a prodrug, it is inactive. Eventually it will be converted into an active drug called enalaprate by the liver. So any drug that is a prodrug is any drug that is inactive. Another drug I can think of is levodopa, which is prescribed for Parkinson patients. And so the etiology for Parkinson is they have low level of dopamine, but we really can't just take dopamine, so we take a prodrug and eventually it will be converted into dopamine. All right, so remember I was talking about liver enzymes. There are many liver enzymes that play an important role in metabolism, and one set of enzyme or family of enzyme is called a cytochrome P450. Very complex system. I'm going to make it very, I'm going to keep it very simple, so just bear with me. So the concept is that you have a set of enzymes that metabolize many drugs, and depending on the depending on some other drugs, when we talk about a drug-drug interaction, or when you take multiple drugs, one drug can speed up the process of the another drug or slow down. We are really talking about these liver enzymes, these cytochrome P450 complex system. So in other words, these enzymes will determine the speed at which the drug will be metabolized. This is one of the reasons that cause drug-drug interaction. So the example I have here is, I know it's a busy slide, so bear with me. I'm going to give you guys two examples. One is where the drug act as enzyme inhibitor, and then the second one would be inducer. So inhibit means I'm going to inhibit, I'm going to slow down, I'm going to stop, right? So slow down. What are we slowing down? Well, metabolism. We're talking about metabolism. So these drugs will make the pathway work slowly. It's going to slow down the process. The metabolism pathway will slow down. Now, what happens when you slow down the metabolism? Well, you are taking longer to excrete that drug from the system. So if it's taking you longer, if it stays in the system longer, you are increasing the toxicity of that drug. So in other words, when you do the blood level, it will be supratherapeutic. Supra means above the therapeutic range. Now, so I think the moral of the story is, when we talk about enzyme inhibitors, we're talking about cytochrome enzyme here. Inhibitors will cause a toxic drug levels. I think that's a takeaway message here. And then the reason it's a toxic, because it is inhibiting the process. It's going to slow down the pathway. The example I have here is a Cipro. Ciprofloxacin is an antibiotic, and I'm going to combine this with naproxen. Naproxen is NSAID, which is a pain medication. So when we take Cipro, Cipro will inhibit. Remember the term inhibit here. So it's going to act as an inhibitor. What it will do is it will result in less metabolism of another drug. This is a very complex system, of course. So nothing happens to Cipro, but Cipro is acting as an inhibitor for another drug. In this case, it's acting on a naproxen. So what will happen is it will lead the higher amount of naproxen in the blood. In other words, we are not going to metabolize naproxen at the same rate as if we were not on Cipro. So you will slow down the process. That will build up the amount of naproxen in the body, and you will have a naproxen toxicity. Now, you can only imagine, let's say, from practical standpoint of view, let's say you have a client who has been taking naproxen for the past several months. Let's say you have a 65-year-old male with chronic back pain, and who has been taking naproxen for the past 6 months, and today he has, let's say, UTI or some kind of infection, and we are going to prescribe Cipro. Let's say the culture sensitivity comes back, and we are going to start ciprofloxacin for this client. Now, so it would be a patient teaching for this patient that, okay, I'm going to give you Cipro, and I know that it's going to increase the level of naproxen. So perhaps if the patient is taking naproxen 2 times a day, 3 times a day, maybe need to cut down or use something else. Okay, can we use acetaminophen or tramadol, Norco, whatever. That's a conversation that needs to happen with the patient, or at least educate, let them know, because naproxen can be dangerous, right? We know that. Okay, another example is Cipro with warfarin, which is a Coumadin. Same thing, the levels of warfarin will increase. You can have a serious side effect, as we know that warfarin if this is a blood thinner and or anticoagulant medication, and you have to be very, very careful when you start any other any antibiotic. To be honest with you, this is one drug, warfarin, that you have to be very, very careful. It doesn't get along with any other drug, to be honest with you. So be very careful when you start antibiotic, which is very, very common. You're going to have a patient with AFib or maybe DVT or PE and so forth, and you know, and maybe you're not checking PT-INRs as frequently because the patient has been on these drugs for a while, and then the numbers were fine, within range, and maybe perhaps you're doing a PT-INR every month or every 3 weeks or something like that. But when you give Cipro, usually but for 5 days, 7 days or so, you know, about maybe 10 days, whatever, 7 to 10 days, at that time perhaps it is a good practice to recheck a PT-INR maybe more frequently, just to be on the safe side, because you really can't hold a warfarin. You know, that wouldn't be a good thing to hold a warfarin and put somebody at risk of clotting. So what I do in my practice is, anytime I start somebody on antibiotic, and if the patient is on warfarin, I recheck PT-INR more frequently. So that's so this is how you apply this in practice. Remember, patient safety, patient safety, patient safety. All right, so that's your inhibitor. Now the second is inducer. So some drugs can act as enzyme inducer. Now inducer means that they're going to induce, they're going to speed up. The previous one was inhibitor, where we were going to slow down, but now we're going to speed up. Well, the problem is when you speed up the pathway, then that means it's working more quickly, you're metabolizing at a fast rate, so that can result in a subtherapeutic level. So the previous one was a supratherapeutic. If this is your therapeutic range, let's say therapeutic range, and the previous was supratherapeutic, it was high, and then this will give you subtherapeutic, below. Okay, so this is below. So I'm gonna just come up with one example. Let's say I don't know, if 10 to 20, let's say, microgram per ml was, let's say that was considered therapeutic range for a drug, you know, called X, Y, Z, whatever. And so I don't know, 5, less than 5 maybe is your subtherapeutic, if that's what you see. And then maybe you have here 100, I don't know, 50, whatever. That's a supratherapeutic. All right, so these drugs level may decrease. The level will decrease more rapidly. So in other words, you will have a subtherapeutic range. Now, rule of thumb is all anticonvulsant. I have phenobarbital here. Pretty much all anticonvulsant should be considered as possible inducers. So be very, very careful when you have a patient on phenobarbital or any other anticonvulsant medications, and sometimes we use them for bipolar reasons. So consider that as a possible inducers. All right. Next, the last step of pharmacokinetics is excretion. Excretion means we are going to remove the drug from the body, and the primary site is your renal function, your kidney. And remember, for metabolism, the primary site was liver, and for excretion, it is the kidney. Almost, gosh, more than 90% is probably excreted by the renal system. Small percentage is excreted by other sites such as skin, especially if it was a topical medication, or lungs if you were using inhaler. Let's say you have a patient with asthma or COPD and you were using inhalers, so that will be excreted by your lungs, or fecal in your stool. Okay, Next topic is drug half-life, another interesting concept. So the drug half-life is the amount of time required or the amount of drug in the body to decrease by 1/2. Okay. The way we write 1/2 is lowercase t and half. So what happened is when we study a drug for 1/2, we're trying to find out how much time, how long does it take for the plasma concentration to decrease by half. So you can have a short half-life or long half-life. That means drug, if you have a short half-life, then drugs needs to be given more frequently. That's how we determine frequencies. Or if the drug has a long half-life, these drug needs to be given less frequently. For example, I'll give you an example in a second, but half-life is inversely proportional to rate of a drug metabolism. What do I mean by that? Well, if you have a higher the rate of a metabolism, if you're metabolizing at a higher rate, the half-life is going to be shorter. That just makes sense, right? If it's going to take you a long time to metabolism, then the half-life is going to be long. In other words, if the rate of a metabolism is high, very high, you're metabolizing at a higher rate, at a faster rate, the half-life is going to be short. Now, rule of thumb is approximately 95% of the drug is eliminated in 4 half-lives. And that is to keep one thing in mind, that the renal or the hepatic function is not impaired, that the otherwise healthy individual, let's say. So if you ever see a question on drug half-life, to be honest with you, the easy way out would be to multiply half-life. Will give you half-life, you multiply that half-life by 4, and that will give you the answer. For example, if a drug has a half-life of 4 hours, then what I'm asking is, how long do you think it will take for the drug that will be eliminated? So the answer would be 16. So most of the drug will be eliminated in 16 hours, because 4 times 4 is 16. So if a drug has a half-life of 10 hours, then about 95% of the drug will be eliminated in, why don't you pause for a second and see if you can come up with the answer. If you have a drug that has a half-life of 10 hours, how long do you think it will take for the drug to be eliminated? And the answer is, go ahead and pause. Yes, 40 hours. So 10 times 4. Remember, I'm telling you that you multiply by 4. And why are we multiplying by 4? Because I mentioned that the rule of thumb is 95% of the drug, not 100%, but it's almost 100, right? 95% is eliminated in 4 half-lives. That's where the 4 comes in. Okay, let's do another example. If a drug has a half-life of 8 minutes, most of the drug will be eliminated in, go ahead and pause and see if you can come up with the answer. Yeah, 32. All right, you guys are so smart. All right. So that's half-life. Now, there's a concept of loading versus maintenance dose. Loading is when you have to give a high amount upfront. Now, before we get into loading versus maintenance, rule of thumb usually is that we start at a very low dose. I mean, I'm sure you know that. With the pediatric population, geriatric population especially, we start at a very, very low dose. For example, if let's say that a medication dosage is 500, for elderly patient, you may want to start at 250 milligram. Okay, especially if you have renal impairment or liver impairment. Now, that's a normal practice. However, there are some situations where you have to give a high amount to prime the bloodstream. We give a large amount initially so that the medication would work more quickly. The examples are digoxin, Plavix, Keppra, Imidazole. Now you see these mostly in the hospital setting. As a family practice in outpatient, we are not necessarily giving loading dose. We keep maintenance dosages at that time. Now, and the maintenance is where you keep the concentration within the therapeutic range. All right. Now, what is your responsibility? Well, to see if the drug has a narrow therapeutic range or not. There are some drugs that the range is very narrow, like digoxin is one of them, and so you have to be very careful. Lithium, we check range, we check levels for Depakote and so forth. So what we're trying to find out is are we within therapeutic range? And if the answer is no, we need to adjust the medication accordingly so that we can prevent the toxic concentration. And some drugs we check peak and trough. Some antibiotics we check peak and trough. All right, so that we can really minimize serious adverse effect and make sure that we are within range so that we can provide a proper care so that we can treat the disease that we are trying to treat. For example, if it's antibiotic, we will be able to treat the infection if the drug is within normal range. And that's all I have for this chapter, and I will see you in next chapter. Thank you.